Good morning or good afternoon, everyone, for joining. I hope that you can hear me okay. Um, Please raise a hand or figure out a way to alert the tech folks if you cannot hear or see my slides. I want to thank the folks at Morehouse School of Medicine for inviting me to participate in their series of webinars on telemedicine. This is a topic that I've devoted my professional life to for the last 15 years. It's particularly rewarding in that 15 years ago, it was Dr. Satcher who took a chance on a kid straight out of training and appointed me the telehealth project manager of the Regional Coordinating Center for Hurricane Response. And that's largely where I learned the two or three things that I know around the field of telehealth. And I've been incredibly fortunate since that time to have worked with all manner of organization, both large and small, and population, largely vulnerable, whether it's the elderly, substance abuse, incarcerated, and what have you, in trying to figure out how to use technology in the best way possible to address some of our very real challenges. And so, in moving forward, keeping those sort of course objectives in mind, I actually elected to take a 30,000-foot approach in looking at how do we go about thinking about and strategizing and cultivating models around caring, in this case, for underserved population in a behavioral health setting. But the ideas and the lessons and the questions that I'm going to raise today actually apply universally, which is perhaps our first take-home message, that telehealth is a much broader, much more sort of fundamental idea than some product or service that we can buy online. And so let's start with some of those broad ideas. This is sort of a condensed version of the telehealth 101 talk that I sometimes give to groups. But in looking at the term telehealth, as opposed to telemedicine, while functionally they may be synonyms, I tend to favor the term telehealth as it tends to highlight wellness rather than accentuate illness. But the prefix tele, borrowing from HRSA's Office for the Advancement of Telehealth, defines it as the use of electronic information and telecommunications technology to support one of three basic activities. The first is clinical services. The second is educational pursuits, which you may know as Project Echo. The third are any administrative work. And any time that you can push that work utilizing technology into your model, the better off you'll be, the more assured your sort of return on investment might be. The root health in telehealth gives me an opportunity to brag about my home state of Texas a little bit. For those of you who sort of track on such things, SB 1107 was passed back in May of 2017, or about 2 legislative cycles ago. I was incredibly fortunate to have been one of the stakeholders engaged in a very heated discourse around the question of what telehealth is and is not. And what started with a lawsuit eventually became a shared understanding in the passage of this bill, which very definitively states that telehealth care is healthcare, full stop. What that means is that all of the expectations that we've come to have around conventional healthcare delivery does hold when it comes to thinking about telehealth care. What this does is a remarkable achievement in sort of making it more clear rather than more opaque around how do we go about legislating telehealth care. This understanding of telehealth care being healthcare is built upon the sort of understanding that all healthcare is founded on a valid practitioner-patient relationship. And when you have this relationship in hand, there are all manner of new opportunity as a result of the technology that surrounds us. And I think that that is the far greater path to pursue rather than saying, oh, technology is so great. What can I do that's very, very different than what we've come to expect from conventional healthcare service lines? Moving ahead, when I think about telehealth, it helps to sort of align certain terms and broad ideas. The first being the prefix tele. There is a risk when we liberally use the prefix tele across all manner of service lines. So whether it's telebehavioral health or psychiatry, telecardiology, telepathology, or radiology, we create this Tower of Babel where over time we begin to think that we're talking about something different. I'm actually reminded of a time back when I was working for Morehouse at the RCC knocking on doors in the Gulf Coast, trying to help restore lost capacity as a result of Hurricanes Katrina and Rita. And I was in the state of Alabama when I encountered a tiny rural clinic, and I asked them what their experience with telehealth was. They proceeded to open a closet which held about $20,000 worth of technology and telecommunications gear. When I asked what happened, they described a very forward-thinking cardiologist from the university who obtained a grant, began delivering services to the clinic, and unsurprisingly, when the grant ran out, the the clinic said that when the grant ran out, so did the services, and they stored the equipment. Having seen the situation before, I had taken to responding by asking them a series of questions. I asked them to show me the phone that they used to call their mother, the phone they used to call their boss, the phone that they used to call their best friend. And after about a second of looking at me like I had lost my mind, they started to realize that the technology that they had in their possession was far more than a telecardiology box or a tele-psychiatry box or a teleradiology box. And it's important that we recognize this broader pursuit, lest we all walk around with 20 cell phones in our pockets to make sure that we're communicating in an appropriate fashion. Moving on, the notion of synchronicity is the relationship of telehealth has with time, whether it's in real time or whether it's in real time or whether it's, in store and forward fashion where the communication is sort of dependent on the recipient's schedule. They have special considerations in the development of these solutions, but they also have special opportunities that can yield benefits that we may not have considered when it comes to thinking about store and forward and how it applies to populations in need of behavioral health services. The notion of competency is probably the idea that I talk about the most. I'm a big believer in looking at telehealth as a competency, as perhaps better said, as a skill to be mastered. Just as I recall back in medical school where all of us were taught a liver exam and how to perhaps diagnose liver disease in 5 different ways by just looking at your hand, this skill is incredibly useful. It is not something that I use in every encounter with every patient. And likewise, I think with telehealth, rather than viewing it as something outside of conventional health systems, outside of conventional provider groups, looking at it as a skill to be mastered helps us recognize and unlock the true potential of seeing where telehealth can actually help existing conventional health systems. There will always be a place for pure telehealth plays, and you see an enormous propagation of pure telehealth services growing all around the country, offering you all manner of services for $49, $59, $99 an encounter. And there's a lot of great things to be said about that. But I tend to focus my attention on how can we lift up, how can we stand up the folks actually caring for folks with pre-existing therapeutic relationship, utilizing telehealth as a skill to advance the care of their patient populations. Moving on, I'd like to briefly sort of discuss the idea of telehealth modeling. As I mentioned before, really what we're talking about is a basic provider and patient relationship. But because we live in the world, healthcare is a far more complicated thing than just simply a doctor caring for a patient. And as our health systems grow increasingly more complex, navigating those systems becomes an increasingly hazardous challenge for our patients, resulting in the propagation of completely new jobs that did not exist a generation ago, like patient navigators. I love patient navigators. I think they serve a vital role, but I think that this is a clear example of us creating solutions for problems that we actually contributed to. And what telehealth allows me to do is to sort of rethink how do we structure our healthcare delivery systems with the patient at the center of it, otherwise known as true sort of patient-centered care. Flipping the lens, when I think about providers and how they have to struggle against all manner of difficulties in caring for the populations they seek to, we seem to be moving in a direction of value-based or population-based health, where my peer group and I are being actively encouraged to think about how we best can take our finite skill and apply it across a big population. And that is a big ask, and it's one that I think telehealth offers some unique insight and unique opportunities to help address some of these incredibly difficult questions. Models have to live somewhere. In other words, models represent tiny nodes within what's called a telehealth network. And when I think about networks, I often reference a 1964 RAND memorandum by a gentleman by the name of Barron, who was hired by the government back then to look at the survivability of command and control centers among our nation's military sites, especially at times of war. And unsurprisingly, Barron recommended the option C, the distributed model of architecture that proved to be the most adaptable, the most resilient architecture in maintaining communication network survivability. Now, I used to, upon initially reading this, think that these were our options, that we would need to pick A, B, or C. What I've come to understand as a result of the work that I've been able to do is that what these things represent is actually an evolutionary timeline, where almost always a telehealth model begins as a single clinician driver creating a centralized model of care with good effort and time and a little bit of luck. That model grows into what's called a decentralized model. You see these in both large health systems and statewide networks. And one day, I hope to actually see a genuine distributed model of care, which would resemble very much like our current understanding of the internet. I don't believe that that network actually exists yet, but I do believe that we are heading in that direction. Looking at the idea of our needs, taking a step back, I think it's important to recognize why there's such interest and such enthusiasm in telehealth in addressing some of our critical care delivery challenges. And it really rests on the very basic principles of the fact that we are spending an inordinate amount of money towards supporting our healthcare system. And more than that, this enormous investment isn't giving us a lot of bang for our buck. And so the idea of looking at serious quality measures on how we're investing our healthcare dollar is going to be super important. And this is where I oftentimes sort of run into a lot of friction around how I go about cultivating and building healthcare models. And that's an issue of perspective. Oftentimes we have to make these sort of difficult decisions of looking upstream, which many would interpret as ignoring the downstream sort of immediate need. And when you're holding on with both hands already, it makes for a difficult path forward in trying to align perspectives so that we might reduce costs, so that we might also increase quality. But once again, I believe that telehealth offers this opportunity to give us just a little breathing room with which to not only address the folks in immediate need coming in our door now, but be able to invest some of our resources, some of our attentions upstream so that we might be able to avoid those urgencies altogether. So from a strategic standpoint, I like to begin again with the doctor-patient relationship. And using this graphic is sort of super helpful for me to recognize what potential strategic opportunities somebody might have. And so as a psychiatrist, I'm trained as both a psychiatrist and an internist, and a big part of why I did a combined residency was that I'd like to take care of the whole patient. But what it really did was it forced me to look in between the two silos of care to recognize the difficulties that many patients have in jumping from one provider to the other, whether it's the psychologist, the therapist, the caseworker, the social worker, or the patient's cardiologist, pulmonologist, OBGYN. It is a treacherous path that our patients have to navigate, and I have a whole slew of anecdotes on ways that technology can really convey this sort of team-based approach to improve communication, to improve awareness, and ultimately to improve the satisfaction that a patient has in navigating an incredibly complicated position. Telehealth also offers us these really unique opportunities to be able to care for more than just the patient in front of you. I can think of multiple occasions where an incarcerated juvenile under my care, I've been able to resolve some of the difficulties in connecting up with their parents, who perhaps hasn't seen the juvenile in months, if not years, who's able to convey important collateral information in my care of the youth that would be impossible under conventional measures. Telehealth broadly creates these sort of opportunities. I've been able to maintain that prison clinic, for example, in Covington, Louisiana, for 15 years. And it's something that I'm super proud of, because I know very few providers who are able to actually work in a prison for 15 years. I love the work, and the people that I work with are extraordinary. Uh, I also like to take an opportunity to share a parable that you may have heard of the blind men and the elephant. For those of you who are unfamiliar with the parable, a number of blind men encounter an elephant. They're all sort of asked to express what it is that they're experiencing, what it is they're encountering, and as a result of their blindness, their sort of disconnected, independent, half experiences sort of translate into this monstrosity that doesn't in any way resemble what it is that they're actually experiencing. I like this parable because I kind of feel that that's where we're headed in healthcare, where outpatient and inpatient or substance treatment services don't necessarily feel like they're connecting up into some broader whole. And I highlight this parable so that, as mostly a plea, that we all try to expect more from each other to make those connections, to make those fine tunings, so that we don't have elephants walk around looking like this. When it comes to goals and how we're sort of proceeding, I tend to borrow from the technology community. If you were to ask any app developer worth their salt, how's it going and when are you going to get the product done, they will say fast, good, cheap. Pick two. This is an incredibly simple and deceptively deceptively elegant way, not naive, but elegant way to describe how program development begins. Because we can't have it all when we want it, how we want it. And recognizing, acknowledging, and building into our sort of service goals the notion that if we want it good and fast, it won't be cheap. If we want it good and cheap, it won't be fast. And ultimately, we tend to get lots of external pressures to offer something fast and cheap. But in that particular instance, we tend to risk things that are less than fully good. As a broad blueprint on how you go about approaching vetting a model that you're considering a service model that you're considering partnering with, building one on your own, or broadly just sort of looking at how telehealth might be suitable for your organization, allow me to use the construct of a house and say that your foundation, of course, is built on that therapeutic relationship. As conventional providers, this is a checkbox that is very easy to sort of establish and creates enormous opportunities, unlike the opposite proposition with telehealth companies, where it's hardest for them to lay that foundation, but after which they have an incredible facility and nimbleness in being able to offer all manner of different services. Upon that foundation, you would have well-articulated service goals, the what that you're trying to do. Like all things, as you sort of develop these programs, I would caution you on trying to shoot for the moon and instead have very, very actionable, easily digestible service goals early on to build upon, and eventually that's how we get to the moon. Your second floor would be resources, the who's and the what's, the personnel, as well as the hardware and the software. The one thing that I can tell you about this domain of model development is that it's a rapidly changing landscape, particularly when it comes to the technology portion. Things are moving rapidly. They're getting cheaper. They're getting smaller. What we're able to do with the device in our pocket was unheard of way back when. The statistic I like to lean on is that an iPhone 6, I believe, could simultaneously launch something like 100,000 Apollo-era moonshot missions. And so we should not overlook the fact that oftentimes the mobile platform will be the right choice rather than what many people have in their brain with respect to very fancy build-outs with high-end technology and teleconferencing equipment. Our third floor is the notion of workflow, the whens and the wheres. This is where I oftentimes, when folks bring me on board to either build or fix up a program, this is where we oftentimes have conversations about how telehealth is not the silver bullet, and nor is it a replacement or something that you would do instead of a conventional encounter if that conventional encounter is achievable. If the burden of a conventional encounter is so great that it doesn't happen, those are the opportunities that we look for about the when and the where you might apply some technology and telehealth solutions towards better caring for your patients. And as we sort of put the roof on this house that protects us from all of the harsh elements, that would represent our reimbursement or financial model that sort of keeps us whole, that keeps the house maintaining its strength and resiliency and continuing to care for our patients. Reimbursement and financing of healthcare, whether respect to telehealth and not, is a time I could spend 3 days on it. I'm going to defer to the question and answer period for anyone who has broad questions, but what I can say about reimbursement is that it's state dependent, it is a moving target, and the only way it's going to move in a positive fashion is with your participation. And we'll talk more about that notion in just a bit. So with any strategy, with any sort of intention of moving forward towards doing better for our patients, it's always going to be filled with challenges. I'm a fan of former Chief Justice Holmes's quote saying that to reach anywhere, we must sometimes sail against the wind, which apparently he was a big fan of sailing. And for anyone who's actually witnessed this, the idea of sailing into a headwind and being able to make forward progress is quite a remarkable achievement. And in healthcare, we face a stiff headwind across multiple domains. Clinically, for anyone who looks, it's not very hard to see how burnout is negatively impacting our workforce. In my state of Texas, I see it all over, and nothing breaks my heart more than seeing somebody younger than I who checks out of clinical practice because they've just lost the joy of the job. And this is going to have far-reaching repercussions, obviously, because it's not easy to make a clinical provider. From a policy standpoint, we continue to be generating a veritable alphabet soup of more and more rules and guidelines about how things should or should not be done. It is a big lift, and it's one that I've learned to navigate over time, but it's also important to recognize that just because intentions were good, ultimate policies aren't necessarily going to be the most helpful unless we participate in the eventual adaptation of these things. I think a great example is the Meaningful Use program, which has now evaporated and sort of been folded up into the macro MIPS initiative. But the heart, the intention of meaningful use is there. We need to find a way to leverage the value out of digitized health information and do it in a way that preserves privacy, but more importantly, finds that right information to the person that needs it the most. As a sort of the opposite side of this coin, from a regulatory standpoint, the chains are moving rapidly in terms of licensure, malpractice, reimbursement, scope of practice. These sorts of regulatory rules, as I mentioned, are things that have enormous potential to be done better in the case of SB 1107 here in Texas, where we're able to carve out a lot of confusion, a lot of alternate or secondary pathways, which only lead people to view telehealth as something separate and distinct from healthcare. Once again, each jurisdiction, the genius, the beauty of our union is that states' rights are and continue to be incredibly important. And so understanding what your state jurisdictional sort of impressions and regulatory stances are is very, very important. But then broadly on the national standpoint, if there's a big enough tipping point, this is how the laws of the land get made. Pulling further out from a cultural standpoint, I believe that a lot of the cynicism, a lot of the nonsense, a lot of the difficulties that we're having in having meaningfully productive conversations around where do we go with healthcare really just boils down to a truth versus power dynamic. This is an age-old conflict where what is good or right isn't necessarily what we do as a group or as a society or as an organization. This is not to say that that society or organization has malintent. This is ultimately how we move as a group. It is not something that is inevitable, and ultimately we need to strike a balance between the two if we hope to make some positive impact in the people that we hope to care for. And so, barring from another Chief Justice Earl Warren, he tends to talk about that in civilized life, law floats in a sea of ethics. And this is where I base much of my faith and optimism that we are heading in the right direction. And it really just boils down to one word, and that's advocacy. I've shared with you the delight that I had in living my schoolhouse rock dream and making a bill a law here in Texas. It was not easy. It was not a guarantee. And for those of you who have even remotely looked into it, making a bill into a law is not an easy process. Don't even bother trying to read it. It is mostly just there for sort of shock value. But this is effectively how a bill becomes a law. And for anyone who's been involved in the advocacy work in your home state, you'll know that our elected officials, both at the local, the state, and the federal level, are incredibly well-intentioned, but it is impossible for them to be knowledgeable in all aspects of human life or in human civilized life. And when it comes to healthcare, they rely on people who actually know how healthcare can and should be delivered. And this is the opportunity that we have to take up that position. And so when it comes to advocacy, the lessons that I've learned now 15 years out of training was it sort of starts from home or the workplace. All those subcommittees and task forces and meetings that are called within your health system that oftentimes generate eye rolls are incredibly important. To share with you an anecdote that just happened with my wife, who's also a physician, she just got back from a dinner with a group of her peers because they had a visiting speaker who happened to be the president of her professional organization, who said, we've got a chair opening for patient safety, which my wife has some experience in. And her first reaction was the eye roll, saying, oh my gosh, I've got so much to do, I don't know that I could do it justice. But being able to engage with those professional organizations, to lend your voice to the chorus of folks who are trying for better, it has been a rare privilege for me to work with the TMA in a number of different capacities. And I encourage you to find your professional organization, to lend that voice towards coming up with a cogent, a common sense solution for whatever problem in addressing whatever population you might be. And so in terms of behavioral health and underserved populations, I can think of a dozen different ways that you can execute this advocacy plan. And then from the third sort of leg of this stool has to do with our elected officials. Believe me when I say they are not unapproachable, impregnable, other people. These are folks that welcome honest, knowledgeable folks who are seeking to assist them in making the best decision they can in creating the laws of our land. And so with that advocacy plan in place, let's look to the future. If I haven't bowled you over with all of my many metaphors and parables and such, I'll leave you with one last one, and that is mountaineering. In moving forward with yourself as a provider, with your group or health system, I encourage you to look at the path ahead as a mountain to climb. And I'm a big fan of Nelson Mandela's quote, who said that after climbing a great hill, one only finds that there are many more hills to climb. And that is, in a nutshell, all of our careers, I believe. And so in moving forward, mountaineering has four primary areas. The trek in, which really represents, you having the goals, cultivating the team and developing that resource plan so that you can even think to summit whatever mountain that might be ahead of you. As you establish your base camp, you want to formalize that game plan. You want to make sure that all of your stakeholders have buy-in, that they're all committed to this plan. And if you're anything like me, you're a big fan of checklists, which is essentially a way to guarantee that you say what you do and you do what you say as you move forward up the mountain. There is going to be a recurring and repetitive acclimation process as you get to higher and higher climbs. What this means for us is the notion of failing fast. You want to iterate, you want to get that feedback, and you want to adapt, because without that adaptation, you're not going to be resilient and you won't survive in moving forward. The final phase of your summit would be the notion, if I could leave you with one broad tip, and that is, when I build something or when I function as a telehealth provider, I seek to be the right provider, with the right information at the right time. I kind of flipped it because leaving you with a broad pit didn't quite sound very good. So, but if in looking at a service you hope to build, in addressing that sort of key population that you're hoping to care for, being the right provider with the right information at the right time is the best simplified way that I can approach what the true value proposition of telehealth care is. It redefines the relationship not in terms of discrete encounters. It redefines a relationship not in terms of a single person, but it really looks at the sort of the functional process of how we can get folks who have a particular unique skill in caring for folks and folks with a particular need for that care, how we can put them together in the most efficient, hopefully most cost-effective, high value, high quality way possible. So I sort of buzzed through that, hoping that we would have an opportunity for lots of different questions, because as a broad talk, I know that everybody would have unique situations and unique circumstances that they may feel unsure about. And so I have the Adobe Connect window open, and I'm hoping that our moderators are going to be able to offer up some questions that were either previously submitted, or feel free to post any questions that my my comments may have triggered in you. If you, for whatever reason, have a follow-up question, you can always reach out to me at connect@agmp.co. Once again, it's connect at